guys. Well, thanks for being here tonight. And as you know, it's late in North Carolina. And one of my colleagues today at the surgery center said, that's late on Eastern time. I'm like, yeah, but we're looking after our California colleagues. So here we go. So as we mentioned, we are kicking a new format off tonight. So the first thing I'd like to do is take your phone and go to your browser, go to menti.com and type in that code 4583-9890, and that should put you right in there. And what I really want to do today before we kick it off, so I know where to spend my time. This is a bit of a choose your own adventure, and based on feedback that I get today, we'll sculpt the next time, and we just want it to be better and better, and for you guys to get what you want out of this, because I tell the guys, if I could go back, 9 months ago, I would go back and delete those recorded webinars because there's so much more I can tell you to get right to the point. It just gets easier and easier the more you do it. And so everybody should go. Guys, are you in? Is everything working well for you? I'm going to wait for Chris and Jordan to give me a little thumbs up. And
it seems to be working. Yeah.
Okay, so we're going to start this one. So we're just going to start easy. Describe where you are in your journey with intraosseous anesthesia. Never seen it before, seen, but have not used. Used in primary dentition, used in mixed, used for all local anesthesia needs. Just to kind of get where we're going. So I know where to put the emphasis tonight. Even though this is the advanced lecture, I know we always have people that are first timers because this just works out for the schedule. So that's looking pretty good. And I think some people I can see are still trying to get into Menti. But this gives, so most of us know what we're talking about, but maybe haven't exactly have done it. And I'll give people just a few more, somebody put mixed dentition in there. So great. Use of mixed dentition is a great pathway on the journey. All right, we're going to continue on here. Oh, they're still coming. All right. I like to always talk about the why when we spend time together on a night after a long work day. The why are the children. That's why we do everything. That's why we love what we do for a living and why we work so hard. These are Dr. Clark Morris's children, my partner in practice and good friend and my buddy at the surgery center. He's my mirror image clinically. And these are his kids. And I want everyone to appreciate the middle guy. That's William. That is basically young Clark. He is holding an inhaler with a spacer. He might have all sorts of reactive airway issues, but it doesn't slow him down. Here we go. And this is the way I want everyone to feel about intraosseous anesthesia when we get to the end of this lecture. And this is back roads of Virginia, heading to Grandma and Grandpa's house. So there's Clark, you can see, and his beautiful wife, Michelle. I just thought that would cheer you guys up. Anybody who can dance with their spacer, that's our guy right there. All right, so I try to take cues from Anne. She's my hero, and she's always so personable, and she talks about her family and her beautiful boys and associated girlfriends with them. So I just wonder, well, first of all, does anyone know that LaRee isn't my first name? It's my middle name. My first initial is E. So I'm going to start this Menti. And these are the names you have to choose from: Euphigenia, Euphemia, Euphoria, or Eileen. Which one do you think is my first name? All right. This is pretty entertaining, I must say. Quite a few for Eileen. Okay. It's getting pretty close. So Euphigenia, for those of you that know the 1993 film, Mrs. Doubtfire, that happens to be Mrs. Doubtfire's first name, right? Euphoria, well, that's my stripper name. No, just kidding. Don't start that rumor. I was young, I needed the money. No, just kidding. I'm just a boring pediatric dentist. Eileen, that was my first car's name because that song, Come On Eileen, was popular back then, and my car was not very reliable. So I named it Eileen sometimes, but Euphemia is actually my first name, or Euphemie, which is really the way my great grandmother would prefer it be pronounced. It is tradition that the firstborn female of every generation of my family is named Euphemia. So Mia, my daughter, so many of you know, her name is also Euphemia. All right, that's you proud of me, Anne? That's my personal thing. Okay, we're gonna do another one. What word comes to mind when you think of a palatal injection? Whether you're thinking about yourself getting it, giving it to someone else, how it feels sometimes when maybe you see that quick blanching and maybe appreciate the separation of that tissue from the palatal bone. Yeah, that's no fun. It's probably just about the worst thing that we do to people, only second to the max anterior, all these things. And here's the beautiful thing. I have not given a palatal injection in the primary dentition since March of last year. And I've only given permanent or mixed probably the fall, and really the permanent actually last Tuesday. I was unable to get an IO on a college aged girl and I'll get into it. She is of German descent. You got to watch those dense bones. All right, so let's get to it. So you may or you may not have yet your device, but if you do, what do you do when you get it? You read the manual. Number one thing. Second thing you do is go to newsmile.com, go to products, go to NewSmile Tech, go to Soan or SleeperOne, depending on what you have. Scroll down and you click on this big onboarding button right here, and a very well written onboarding program you get to get involved with, and it's very good. You also contact these guys. They are the absolute best. And what they're doing right there is preparing chicken to do IOs on. Or in Jordan's case, he's done with that work. Now time to have his hearty breakfast next to those nasty raw chicken bones. But contact these guys. Another great thing to do is go to the Facebook group, the NewSmile Tech user group for Soan and SleeperOne devices. And this is the QR code for that if you have not yet found that group. And I love this. My daughter taught me this in high school. They taught her this in high school during a retreat. Don't yuck my yum. If you don't want to do this and it's not for you, well, don't do it. If you don't understand it, reach out to someone that can help you understand it. But don't spread false rumors or negativity about something you don't understand. And how can you better understand it? Well, there's my QR code. You can click on that and upload all my personal contact information. I hear from people every day and I love it. I love sending the successes. I love sending the questions. I love sending issues you're having, because guess what? I've had every issue that you're having now. I've done it and I can help you. And this is my beautiful family. Who else can you call? Well, there's many of us. These are people all over the world that have been doing this for well over a decade. But in the US, Anne made these cute little boxes for us. You have Anne and I as the main contacts and the educators via webinar. But we also have several other educators who can help you, all of these guys. And as mentioned, Anne will be teaching August 7th, and she is amazing. I sometimes listen to her recorded webinars when I'm doing things, driving and so forth, because she's just that great. So don't miss Anne, go see her too. Getting on with it. All right. What one action, if you're saying to yourself, how am I ever going to cross this bridge and be more confident with this? Based on all the things I just told you you can do, name one action, and you can write out a sentence, you can write out something you're going to do. Name one action you're going to do. It could be go visit LaRee. Practice is a great one. We usually have at least one doctor a week fly in and spend time with us, usually a full day in the practice. We got one response practice. No one else wants to take action on it. There's so many things you can do, but it's okay. Throw away the syringes. This is true. I will say, until you commit, you're not going to learn. And educate, whether you're educating, I love whoever that is, come see me. I love it. We have so much fun. Training your team, it's a great way to do. Graduate from residency or get your residency program to get a device. Practice on my boss, yes, but remember, adults are more challenging. Don't stop using it. Keep practicing. And yes, you guys have the right idea. You have to commit. No matter what you're doing in life, you have to commit that you're going to do it. You have to get a little uncomfortable while you learn. And then the sky opens up and a rainbow comes out and the birds sing. I promise you, this is what you want to do. Okay, so we're going to get on to the devices. We're going to do a quick review. Everybody asked me this, why would I buy this one when I could buy all these things? These devices, the dental high-tech devices, are the absolute only devices that are truly intraosseous, have a special needle, and have a pen grip. Everything else is some combination of it. So what are we doing? Instead of aiming for a nerve to anesthetize a nerve centimeters from where we're actually planning to do the work we're doing, we're going to the source. We're anesthetizing the nerve right at the apex or apices of the teeth so that indeed we are getting the anesthesia we need and not a whole bunch of anesthesia that we don't need. And we're also not opening ourselves up for missing blocks or perhaps infiltrating in a way that doesn't really capture what we're trying to capture. And this is the target. We're not trying to stick the needle there. We're just trying to get the solution as close to the target as possible. So the way these devices work is we come in, we make sure there's a D, it's pointing out. Why are we doing this? It puts the bevel down. It blanches this spot. I like to have 4 to 5 millimeters of blanch. We want to be sure we enter before the base of the papilla so that we blanch, the needle tip is in the base. Then we come through, pop through the periosteum, and we pop into the trabecular bone, and we begin releasing our solution, and it goes through the Haversian and Volkmann canals in the bone, and ultimately so beautifully bathes our teeth apices in the solution, which captures the nerves before they enter the tooth and provides the anesthesia that we need for the teeth and also for the soft tissue that is attached to the alveolus. That's how we do it. Okay, so with primary teeth, of course, things are a little bit different. We have developing permanent tooth buds under there we need to be extremely cognizant of. When I first started using this device, someone said to me like, oh my gosh, what if you like stick that needle in one of those developing follicles and unload a carpula solution? I'm like, oh my gosh, what if I stuck the needle in their eyeball? That would be really bad too, probably worse, right? No, we're just not going to do that. You never, ever give an injection into a place you don't have a radiograph for. You want to know what's coming. So people often ask, does this cause pulpal necrosis? Because we're delivering the solution at the apex of the tooth. And is it hypervasoconstriction? Is it doing this? No, it's not. And then the other question that's so common is, why do I want this over the WAN or the STA, the single tooth anesthesia? Well, for all those reasons. So first of all, the wand is basically a periodontal ligament device. That's why it does one tooth. You are anesthetizing one tooth. And we see so much, and we're supposed to call it molar hypomineralization now, but we see so much, this article back in the day where we called it enamel hypoplasia, we see so much of this in our practices. I mean, every day of my life, I see this. And so I personally, after this article was released showing in rhesus monkeys that when you delivered a PDL injection to a primary tooth, that they did indeed see hypomineralization on the permanent teeth, that was enough for me. So I don't use PDLs on primary teeth and frankly don't need to. And as far as permanent teeth, now that I have intraosseous anesthesia, I'm just not doing that either because it is so extremely effective. But this is how it's different. You are not going to get pulpal necrosis. So let's talk about this. Before we talk about diffusion, I want to just clarify a couple things. This is the permanent dentition. The diffusion I'm about to show you is very, very predictable with a short needle in a primary dentition. But one of the things I've learned where perhaps people are calling me and say it's not profound, or perhaps I'm thinking, well, I don't think that was as profound as I thought it was, is the difference that when you're using this in mixed, in late mixed, in the adult dentition, what's happening with a 9 mil needle, which I'm recommending, is we're no longer actually delivering an osteocentral intraosseous injection. We're now delivering an intraseptal injection. So an intraseptal injection, so for example, if I gave an injection right where this dot is, On a child this age with a 9 mil needle, that is no longer centroosseous. This is now intraseptal. So, or osteocentral, as I should call it. So, what we would expect to see with an intraseptal injection is just one tooth in front and one tooth behind, because we are not getting into that osteocentral area where the diffusion can get as far as what you're seeing on these diagrams. So if this were the primary dentition, yes, I would expect 2 teeth forward in the maxilla, 2 teeth distal. So 2 mesial, 2 distal in the maxilla. I would expect 2 to 3-ish. I should say on the maxilla. I would say 2 is more safe, and on the mandible, 2 mesial and 1 distal. But on the permanent dentition, using a 9 mil needle, I would just expect to get 1 in front, 1 behind. Now, if you look at all your data, it'll say use a 16 millimeter needle, but it's very hard to get intraosseous in a later mixed and adult dentition using that needle, because you have to really be so precise directing the force along the long axis of that needle, and that makes it more challenging. So I suggest use a 9 mil for everything intraosseous. Just know when you switch to late mixed and permanent dentition, you consider it intraseptal. But back to the little babies. So when we give an injection here, very predictable that we're going to anesthetize those 3 teeth. We give an injection here, you would expect you would get the max anterior. Now, to get 6 teeth, 3 each direction, I'm delivering in this scenario, this is a child that's going to weigh at least 40 pounds, so I can deliver an entire carpule, a 4% articaine, and I have switched exclusively to 1 to 200,000 epinephrine to increase my diffusion, because I really am not worried about systemic effects of local anesthesia now that I exclusively use intraosseous. So something to think about. The other thing to think about is with these devices, you cannot overpress the trabeculated bone. So they're going to deliver at a force, and at one point they feel too much pressure, they're going to retract the needle. So that means you just can't squeeze the syringe for all of its worth and get the majority of the solution out of the syringe. You really never truly get a full carpule out of these devices. I would say you probably leave a little less than 1/8 behind every time. One thing we love to see, it is our confidence marker. When you see blanching, as you can see all the way to the distal line angle of especially tooth C, but you can see over here, that tells you there's only one way it can blanch, and that's if you have this adequate diffusion of your solution and the epinephrine has reached there, therefore it's blanched the tissue. And this is my confidence marker, but more so on the contralateral side, because again, you never deliver a palatal injection again. Well, I shouldn't say that. I'm gonna give you an example of a child you would want to, but if you're delivering from the buccal and I am using the device and I'm planning to be involved in the pulp, or I'm removing a tooth, if I don't see contralateral blanching on the palatal or the lingual, depending on which arch I'm in, I'm going to move to another site and add some more to make sure that I have profound anesthesia. So again, here, this is the lower. The beautiful thing is intraosseous anesthesia does not have a midline. It's not chasing nerves. It's simply filling a container with solution and bathing the apices of the teeth in it to provide anesthesia. So again, these are the areas that we can inject, but I caution you with the permanent dentition, if you're using a 9 mil needle, just plan for it to be intraseptal. The needle is amazing in itself. If you did nothing else tonight other than learn about this needle, which is like a little baby scalpel, and you order it to go on your conventional syringes, you've done a favor for your patients. It does not hurt. And when it goes in properly, you don't want to stab in because that hurts and you have to go deeper to get the bevel in. It doesn't hurt. If you stab in and you touch the periosteum, that is where there's a hypercongregation of nerve fibers, and it really helps. So using this needle properly, that doesn't tear. If you head in and you keep the D on the tip out, it puts the bevel down and you don't have to get anywhere near the bone. And you deliver your solution, it will not only blanch and anesthetize the mucosa, it anesthetizes the periosteum, that outer layer of bone where we really feel discomfort. And that makes it possible for you to pop through it without any discomfort. And then once we're in the trabeculated bone, That is where there's only pressure sensors, and that makes it a virtually pain-free injection. I like to say virtually. One's perception is one's reality, and if someone's particularly pressure sensitive, then they might make a noise, a grunt or something. They might feel something, but it's not going to be like a conventional injection. So again, we don't want to go deep. Bevel down, don't go deep, and stay off the bone with the initial step. People ask all the time, do you retract and change the needles? What do? You do all this. I frequently do half a mouth of dentistry because we can be anesthetized and immediately start working so quickly. If I do not have any issues getting the bone, I like to start in the mandible. It's generally a little bit more dense and it just goes through like butter. And let's say I did a half a carpal and lower arch, I'll immediately go to the upper and I will do that. If I struggled getting in the lower arch, let's say this child was 12, maybe I struggled a little bit, I would absolutely 100% switch the needle out before I go to another area. Absolutely. And just as a reminder, if you are in the same quadrant, just a couple teeth ahead, and you're thinking you're doing an intraseptal injection on an older child, you don't have to do the blanch step again. You can just go through and pop in for the intraosseous. But of course, if you're changing arches, you want to do the blanch step again and go through everything. I want to remind everyone, and we're going to talk about this a lot tonight, because this is sort of my like, whoa, epiphany, like, oh my goodness, I can see the light. Take time to read your radiographs and understand the bone you're getting into. Take time. When bone is not well organized, it's been sick, it's been infected, it's remodeling, it's modelly looking like this, it is so easy to pop into it. That needle just shoop goes right in. And by the way, I want to clarify, this work is not from our office. This is an emergency sent to our office. But in this situation, because these teeth were terribly infected, we of course always want to switch the needle. We follow the same principles with intraosseous anesthesia as we would conventional local anesthesia. You don't want to anesthetize a quadrant with an infected tooth with that needle and then go put it on the other side of the mouth and pass that bacteria over there. You want to keep things clean and switch it out. So the 3 stages: blanching the mucosa, doing the periosteal anesthesia, penetrating the bone, and delivering the anesthetic in the trabeculated bone. The circle of safety, I like to teach everyone, we want to keep a firm grip on our little friends. We don't want them to move. Make sure they're secure. You have a pen grip on the device, but you have a circle of safety so that your friend doesn't move and cause a hub separation. Also, I recommend using a pillow anytime you're doing anything in a child's mouth for safety, especially injections, to make sure, and hand pieces to make sure we don't have any inadvertent pulp exposures they bite onto or hub separations. And I love showing this little friend. She's brushing this kid, and she just did this all on her own. I didn't say, hold it this way. She's like, I got you, kangaroo. Get your teeth brushed. This is Clark's finger, and I think it's a great example. This is primary or mixed dentition model. But what we can see here is with these devices, because we are not injecting through muscles and in soft tissue, massive soft tissue, you can get that hub right to 1 to 2 millimeters sticking out, where I caution you never to go less than 5 millimeters with a conventional injection. Hub separations are a real deal, and you don't want to be involved with that. And that's basically what you're doing. You're going right between the teeth and delivering the anesthetic there, because these are primary teeth. This is an osteocentral injection. So what we would expect, and this is a mandibular arch, is we would expect to get 1 tooth distal. If there were 1 there, it's been extracted on this mock-up, and then 2 forward. And again, if you were removing teeth, you would want to see blanching on the lingual in this situation. Okay, topical anesthetic. If it makes you feel good, use it. I can tell you I have not used topical anesthetic since March of 2023 when I started using these devices. If you do the blanch step properly, it is painless. I do use nitrous oxide a lot when we do conventional treatment in our practice, but the kids just don't feel that needle sliding through. And then when you step on the device, which I'll get to, it delivers so slow, they're just not sensing this. So no more topical. And it's really funny. There's some kids that the other day, and we had a visiting doctor, had a mouthful of sealants in 1 quadrant of dentistry, and I put the isolite in there, and the kid fussed, and oh, I can't do this, you know, okay, all right. And then I got ready to anesthetize to do this quadrant of dentistry, and it was complex. It was pulp zirconia crowns and so forth. And I anesthetized. The kid did not say a word, nothing, didn't feel anything, put a raincoat on, fine with that, did great for the operative part, and the sealants fussed the whole time. You just never know. So what does it feel like? When you pop through the bone, oftentimes it feels sort of like poking a straw through a juice box, but you don't always feel that. I would say 50% of the time, I don't really feel myself so much pop in. I just see the needle disappear and I know where it's going. But when I come out, I frequently meet resistance. So you want to twist when you come out so you don't pull strong. So we're just going to do a little quiz because this is so important. And I'm going to just make sure everyone understands what we're doing here. So if you don't have a device, this is going to be a little bit more challenging. For those of you that do have a device, this is even more important, but there's a lot of confusion and I get calls. There's 2 pedals that we use. So when you are delivering via the inner pedal on your intraosseous anesthesia, what step are you doing? And it's okay, by the way, I can't see phone numbers or anything. It's completely anonymous. What step are you using? All right. Any other takers? All right, we have some users with a good grasp. That's exactly right. The inner pedal is absolutely only used when you are delivering the first step of anesthetizing the mucosa and the periosteum. Here's another really important thing, really super important. It doesn't matter what color you're in, what setting you're in, it will do drop by drop regardless. The color really matters when you get to the other step. You need to be in blue for bone, and we're going to get into that, just seeing who knew how much time we need to spend on some different things. Whoop. So people ask me all the time, oh, I'm not going to use this device. It'll just slow me down. It takes so long to deliver. It just doesn't. And by the way, if we're giving compassionate injections, it should be taking us this long conventionally. We should not be delivering more than 1 milliliter per minute. So this is just an example of a schedule that Clark and I would routinely keep. The larger blocks of time are for operative procedures. And this is pretty common. We huddle at 6:30. We see our friends from 6:45 to 4:30, and we wrap up by 5 p.m. And we'll go through some things. I want to let everyone know it's such a common thing, like, oh, I got this device. I don't want to use it on a patient. Most people sacrifice their significant other, like, lay down, I'm going to poke you and see if this thing works. But what you need to realize is you are basically, let's say, like, oh, I want to become a runner. And instead of signing up for a fun run or perhaps a 5K or something, you sign up for, the Umstead 100-miler endurance run or something like that. You just don't jump out like that. Make sure you start in the primary dentition. A great way to start, which I actually learned, my dear friend Bobby Elliott was the first to talk about, like, hey, I did it while kids were sleeping under in-office GA. And I was like, oh, that was smart. I should have thought about that. But I wasn't as smart as Bobby. But that's a great way to start feeling what it feels like. You can practice on the chicken bones, attend some of the workshops. Then you want to graduate into the early mixed dentition. I give credit where credit due. I learned from Dr. Alp how to do the twist to try to drop in. And then ultimately, Dr. Pren was my mentor. He helped me out. And then ultimately, by January, I use it for every single friend. And like I said, I had 2024. The very first friend I had in the office, because I use it on everybody. We keep kids until they're 22 and special friends way later. The first friend, I just could not get in, and she has a very strong German descent, and she has bone of steel. And I just still used the device and used it as an infiltration in the upper arch. So here are the 3 needles. And if you're still using your device conventionally, so for example, back in March of 2023, I would use the device to deliver a block if I was taking out a permanent lower molar. But now, and then I tried to do, as the book said, to use the 16, the white, like, oh, it says I need to use this for permanent dentition, and I had a lot of bends. Now I use the green for everything. And I just intend that if it's an older child, that I am actually doing intraseptal and I'll inject in more than one place. But you can use these conventionally. One thing I like to tell people all the time are more doors are open with kindness than force. When you're trying to get in through the bone and maybe it's a little older child than you've tried before, just take a breath, take your time, rotate it in your hands, think about navigating through the labyrinth of that periosteum and popping into that trabeculation. Because if you get in a hurry or you get frustrated, you're going to bend needles, and you're going to bend needles. That's just normal. Don't worry about it. It's going to happen. We all do it. So don't be fine. Switch out the needle and get another one and try again. So the devices, people ask me about cost all the time. I hope these are the current costs, guys. Maybe I need to update this. This is probably an old slide, but see these guys, it's around this cost if this isn't exactly right. I'm going to talk about the benefits of both in just a minute. People ask me about other expenses. The containers are $30 a piece. And the important thing to do is make sure your team does not throw them away. They look rather disposable and they should be autoclaved. How do I know? Because our team, in the process of a double doctor day, we have 6 devices, threw away more than $1,000 worth of containers. So make sure that doesn't happen to you. And of course, I didn't realize it until the garbage went out. The garbage people came and we didn't have any containers. And Jordan had to emergency send containers to me. As far as the needles, the standard needle is 18 cents. So we're talking 9 cents more. This is worth it in itself. These needles are exceptional. All right, this happened this week. All sorts of things this week. My first failure of getting an intraosseous in 2024. And, you know, having owned a business for, well over 2 decades, I will let you know, you kind of push the limit on supplies because they're expensive, especially when your team throws away over $1,000 worth of them. So this on the screen is what the container should look like. When they start showing these little spidery things, that's when you need to replace them. I pushed the limit, pushed the limit, pushed the limit, and of course had a visiting doctor when this happened. First friend of the day, and they had a few of the little spider web things, and I heard this clink, and all of a sudden glass was all inside the container. It doesn't come out of the container. It's perfectly safe for the child. And anesthetic solution filled the container. And then I quickly took it out because I was worried that the anesthetic solution being near the plunger could cause something. The plunger is very sensitive in these devices, cause an issue with device, and cleaned it out. But yeah, that's what happens when you don't follow instructions and replace your containers. That happened Tuesday. So there you go. Replace your containers. So again, you can use the device for inferior alveolar, you can infiltrate with it, you can do intraosseous, obviously you can do intraseptal, you can do PDL, you can do anything with these syringes as you can with anything else. And these are not my fingers, this is the mama's fingers, but I have not seen a chewed lip since early March of 2023, or a cheek or a tongue, because there is no peripheral numbness. There might be paresthesia, because oftentimes we anesthetize near the mental nerve, and as it exits, they might feel their lip feels a little funny, but not to the level they're going to chew it like this. Very different. So you got one shot literally to win them over. We want to be compassionate. We love these children, take care of them. We know the catalyst and the continuum of fear and pain, perception, the neurologic pathway, and the loop cycle that we create every time we introduce pain to one of our patients. And we don't want to be responsible for that. We don't want to be at the cocktail party listening to some drunk friend talk about how much they hate the dentist, and we can stop it right here. So let's start doing it. So the SleeperOne, I love this thing. I like keeping it simple. Just keep it simple. You push the pedal, it goes. It has 3 settings. We have 7 doctors, going to have 8 next month. And sometimes I pick up the Soan and the settings changed. I love this thing. I know what it's going to be. It's the same thing every time, every single time. It has a cord. I don't care. I think the kids like the cord, but I love this one. But we do have 3 Soan as well. But this is back to the SleeperOne. So another thing I like about this, I like the bright inner pedal. This is my peripheral vision. I can see it better with my loops on and everything going on. There's 3 settings. The important thing that I want to tell you here, even though this is in French, is that the orange setting, if you're doing an inferior alveolar nerve block, you absolutely must use the orange setting. And after you get at least 1/8 of the carpule through, you can step on that upper left, which happens to be the retraction of the plunger as well. But if you do a quick tap, it retracts the plunger. If you tap or press and hold, it aspirates, so you know you don't have an aspiration. So again, blue is for intraosseous with this device, pink is intraligamental and palatal, and orange is infiltration and inferior alveolar nerve block. And again, must be on orange. So important to know this. The inner pedal is only for that first step. And there is a little setting thing in the back. Just don't touch it. It doesn't need to be touched. It speeds things up and it's just unnecessary. The Soan, you know, it's sexy, it's cordless, it's the latest and it's the greatest, and it's all those things, and I use it every day too. But the difference is there's a whole lot of settings. The inner pedal, it's slightly different color. It doesn't really show it that well, so you can see it, but it only has 2 colors. Blue is for intraosseous, intraseptal, intraligamental, and palatal, but pink is for the infiltration and inferior alveolar nerve block. And you must correlate the device. If you get more than one device, which I recommend, one for every chair you do operative in, keep it easy. You have to have the correct pedal with that device. Otherwise, it doesn't work. I learned the hard way. There are several options with the Soan. There's sounds and adjustment of injection speeds, and you can have it on cruise control. You can do all these things. I would say put it in drive, especially if you're new to this. When your children get their driver's permit, or when you got your driver's permit, you didn't jump in the car and say, let's put it on the cruise control and take it out on the highway. You controlled it with your foot, and I like doing that. Talking about needles just one more time. I just want to focus very much on this lower thing. Osteocentral, when you look at the diagrams, this is what this is referring to. So you will get osteocentral if you're using a 9 mil on the primary dentition. But with adults, and let's face it, a lot of our mixed dentition children are adult size, you really need to go up to the 16 millimeter. So keep that in mind. And again, you can do this if you're amazing, and I'm sure you're more amazing than I am, but I strongly recommend you stick with the green and just consider it being anesthetizing the tooth, mesial and distal. Okay. So let's talk about this. Oh, somebody's already jumped in. We're going to jump in with them. So answer according to your understanding, because we're going to shape the rest of our course today by this. So I'm going to start this. So you can jump in. Somebody, I don't know how you skipped ahead before I did it, but way to go. So I understand the concept of an intraosseous injection. And you slide on your phone, just slide however you feel about it. I know how to use the device regardless of the method of anesthesia delivery. So what this means is I've used it for an inferior alveolar. I can do that. I can do an infiltration. I can do intraosseous. I'm mastering it. The next one is I know how to decide where to give intraosseous injections. And this one is really important to me because this is going to tell me how much I need to dive into the next section. So if everybody can just kind of, and these are giving me averages of all you guys. So most people are understanding the concept. Seems like most people I'm encountering just use it for intraosseous, and if they don't have success, they pick up a conventional syringe, which I don't recommend. It's still more compassionate to use these devices because of the specialized needle and the digital delivery of the solution. It makes it much less painless. All right, so seems like we can just skip on to, okay, I got you guys. Let's keep it going. So again, it truly, in most situations, is a single painless injection. There are exceptions. If there's an infection, but there's not a sinus tract, the bone is highly pressurized. Sometimes when you add local anesthetic, this enhances this pressure and it's not comfortable. So sometimes you need to, even in the primary dentition, you need to give injections in more than one spot to make sure they stay comfortable, and obviously see that contralateral blanching for invasive procedures. Also want to point out, sometimes kids are doing great, because if you look at the slope of this delivery, it starts really slow and then it starts amping up. And if you hear a child do like, or something happens like that, it's probably because they felt that increase in speed and it's pressurizing them a little bit more. And you'll see that pressure. And I'm going to show you examples of the pressure indicators in just a minute. Just be cognizant. Usually, if they're making that noise, they're feeling pressure, and you almost immediately, simultaneously, will see the pressure indicator showing that. It's kind of like if you're doing a sedation, you're like, you're looking a little bluish on the lips, and then you look at the pulse ox and it's starting to go down. So be a good clinician first, listen to your patient first, read your patient first, and then look for the identifiers on the device. A good clinician will always supersede an electronic device in making sure they're taking good care of their children. All right, other things. We consider an infection basically a traffic jam. If you think about the Haversian and Volkmann canals as this interstate system, and you put an infection there, you just clogged it with an accident, especially if there's loss of bone. You can't travel through a bony space where there isn't bone. So in this situation, I would give multiple injections because there's deep caries on the tooth mesial, just to ensure we have everything taken care of. I call this the exit sign. So many people, so many times we've all done this, and it's usually D through G. We give an injection, and as we're giving an injection, the solution's just coming out the fistula. That's an exit. So we don't want to do that. That's not worth anything. So in that situation, we'll give an injection there. I try to do there. And even though it doesn't seem like there's a lot of bone, and we're going to dive into this in a minute, this is a two-dimensional image of a three-dimensional situation. And if you are not in bone and you're in the PDL or up against a tooth or something like that, the pressure indicator is going to tell you that. So here's a really sad situation. Who would have thought just a couple little baby teeth could do all of this? This is just so sad to me, but we see this, I mean, it just all the time. So in this situation, I want to talk about thinking out of the box. If you look at that level of infection and that diffusion of, basically highly acidic, pressurized environment, the approach you want to take is probably not to go from the facial. In this situation, I would say very compassionately, I would likely plan to blanch right at the papilla as usual, and then maybe let it be a little bigger blanching so it can sneak through that diastema. And I would actually approach through the palatal, through the blanched area. And I would approach through the palatal so that the bone that's intact on the palatal aspect can allow the diffusion of that solution and really start making things happen before we get into the other area. And this is definitely a situation where after I got really good release and diffusion on the palatal, the last thing I would probably do is come in from the buccal. And these are two individually terribly infected teeth, and I would try to go right down the midline and get them, and that's the way to approach it. Here's another situation, and this is the really smart reminder. Sometimes in chronic infections, we see disease that passes past the mucogingival junction, which I call the Great Wall of China. Your intraosseous anesthesia does not cross the mucogingival junction. So if you have a friend like this, has this chronic infection and has this gnarly root up in the free gingiva in the vestibule up here, you're going to start with your intraosseous, but you're going to come up here and do a little infiltration around there, because that flap of tissue that mangled root is connected to is absolutely not anesthetized. And we don't want to hurt our little friends, like a little mean little monster sticking out of the garbage can there. We don't want that. Here's another situation. This is a really interesting one, and I will be completely honest with you. I do a ton of restorative. I generally use a raincoat for restorative. And in a tooth like this that is already sensitive due to molar hypomineralization, I will get a raincoat on that thing, and I will flip that operculum back, and I will try to help this child out restoratively, because there's a couple things I know. One, there's a tremendous difference between acute pulpitis and chronic pulpitis. Acute pulpitis is much easier to address from a local anesthesia standpoint. If you look at the literature, the endo literature, our literature is not good for this, the endo literature, it'll show you the sooner you address these things and start diffusing the sensitivity and the pulpitis, the better they're going to be. But I will tell you, I recently learned, like, why am I getting profound tooth anesthesia, but when I push on this little operculum, I get a little from my friends? And then I was like, well, dummy, because this is not connected to the bone. And this is not this little flap of tissue that I normally just push out of the way with my conventional means 18 months ago. That's no longer a thing. I need to actually go in and anesthetize this tissue. I'm going to push back and keep them comfortable. So I would do an intraosseous injection, the mesial of the 6. I would make sure I had contralateral blanching to ensure I had appropriate diffusion. And then I would go back and I would do just a couple drops, probably with the inner pedal, just so it's real compassionate, right into that big hunk of operculum, just to make sure I can push it out of the way. And it'll push out of the way, and it'll stay back with the raincoat because it's full of collagen fibers and fibroblasts, and it's very malleable. But if I don't anesthetize it, that hurts. So something to think about. All right, epinephrine and local anesthesia. So just remember, back in the day where it was our friend, it kept us safe. We always used it. We love 1 to 100,000. It's no longer a thing with intraosseous. It does decrease diffusion. It increases the working time, but you're not getting up with these friends. You're not leaving. You're going to anesthetize them and stay put. You don't need that. It also reduces toxicity via reducing diffusion and the rate of systemic absorption, but we're not giving infiltrations, and we're surely not giving inferior alveolar nerve blocks. So epinephrine's use, it's still a good thing. For me, now in my journey, what epinephrine tells me with the blanching is I have this beautiful diffusion, so I feel good about it. It's my confidence marker, but it really no longer plays a role in the safety, because this is the safest way to deliver local anesthesia for children. And it might actually hinder what I'm trying to do by decreasing diffusion, because I want it to diffuse through the bony space. So have to rethink what we're doing. And again, I love these slides. These are from Dental High Tech. The closer we are to the tooth, the less local anesthetic we need. The further we get away from the tooth, the more local anesthetic. Same thing with the vasoconstrictor. The closer we are to the tooth, or we should say at this point, the further we're from the tooth, the less epinephrine, 1 to 200,000. The closer we get to the tooth, we can use 1 to 100,000. So can you use lidocaine? Yes, I recommend articaine for all the reasons. Super safe, and it's more lipid soluble due to the thiophene ring. And also, we see a lot of children with seizure disorder in our practice. Theoretically, we should be calling for a liver panel for children on long-term seizure meds if we are giving them lidocaine, but you don't have to with articaine, especially delivered intraosseous. And due to the ester group, even though this is an amide, it has an ester group, so it is metabolized via hydrolyzation in the plasma, and the byproducts are inactive. So these are all the reasons that I like articaine. Okay, and it's safe. Just want to be, this is my disclaimer. If you read your reference manual, which you should every single year when it comes out, thank you to all our colleagues that work so hard to put that together for us. They're amazing. You should read it every year. Our reference manual will tell you that the American Academy of Pediatric Dentistry now agrees that articaine is deemed safe for children. It used to not be that way. When I trained, straight to hell for using articaine. You can't do that. You have to use lidocaine or mepivacaine or something like this. But now they clearly say it's safe, but they do say the manufacturer says you cannot use it in children under 4 years of age. Keep in mind, the manufacturer's recommendations are based on conventional measures of using this local anesthetic. I use articaine every single day on children under 4 years of age. And the difference is I'm not introducing it via block or infiltration. It's only IO, and it's very, very safe in that manner. And it also is more effective, faster acting, diffuses better, all of the things that we know. Now, the faster acting using intraosseous doesn't matter because it's all ready to go as soon as you deliver your solution. And again, I don't know how many here on the call tonight see those with special healthcare needs. We see many children with special healthcare needs. So if you have a child that has hemophilia and you are giving a nerve block, you're giving inferior alveolar, you absolutely have to, in most cases, always consult with the hematologist. You have to deliver factor, which is extremely expensive, and it's a big hassle for the family. Oftentimes, after consult for those with hemophilia, and you're telling them you're doing intraosseous, obviously not removing a tooth, but doing a restorative procedure, they're fine without factor now. So that's really nice. And we already talked about those with seizure disorder. I'm not going to get into this because I want to get into a day in the life, which is a request by someone to do this. But I just want to let everyone know that when you are seeing the permanent dentition and you're working, if you're doing something that's going to take you a while, particularly, you might choose, let's say, instead of being these mesial defects, let's say these were peg lateral buildups, and we were going to be there working for a while and so forth, so on. You might go ahead and anesthetize both, depending on how efficient you are. But if it takes you a while to get it just right, take your Bully gauge and you're measuring and you're doing all this stuff to get this perfect peg lateral buildup, just remember when you get to the other side, you might consider just adding a little bit. And that's an example of needing to do some more. And these kids do really, really well. And you can see I have a firm grip on our very anxious kid. Delivering that blanching stuff, that's exactly what that looks like. And then once you do that, and all of us pediatric dentists absolutely over blanch because we're so paranoid we're going to hurt one of our little friends. When we get it really well, I'm going to go ahead and start this one so you can see it at the same time. Then you come out, I like to dab it with a little 2x2. I don't want anybody to taste anything. And the D does not matter. The D doesn't have to face out at this point. And then you can see the little rotate, 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 and then it drops in. And you can see the other one. And I must have came out to try to get another little go at it. And it's okay. If you're not sure you felt the drop you want, it's okay to come out and drop back in, because guess what? They don't feel that. Everything is really great. And you're just going to come in, you can see this one, and we're going to rotate, rotate. And I like to stabilize the other finger, and there it goes in about 1 millimeter out at that point. And this is after we got her fixed up. How old can you use these? You can use them on everybody. Routinely use them on grown-ups. Pressure indicators. This is on the Soan. You see this one little flashing light. That's normal. 2 is fine. When it starts getting up to 3, you might consider backing out a little bit. You might consider taking your foot off the pedal. Maybe you're working on a tooth that's infected and then stepping on it again so that you deliver slow and you don't have that pressure. You're going to see it get a little bit higher in just a second. When it gets to the 4, it's going to stop and retract. It will not let you overpressurize the bone. All right, this is the day in the life. So this was Heidi came to see me, and she is a friend of Tony Sato and a good friend of my friend Bobby Elliott. It's such a small world. And she said, hey, I want to come see you. I want to see this thing all day long. So this is the schedule when she came to see me. The happy faces were sealant only appointments, and we'll just unpack the other. So we're going to go one by one through this just to make sure everyone sees each case and approaches it with the ease I do through the steps that I do to make this happen. So here we go. This is Abigail. She weighs 85 pounds. She needs an OL and 2-3. So we gave 1 injection, 3/4 of carpule, 4% articaine, 1 to 200,000 epi. So here's this 3. And when you look at this bone, I really want you to appreciate. So Abigail is easy. She's a chip shot. Why is she so easy? Look at the crest of this bone. Do you see how this trabeculation goes right up to the crest? Very easy, easy, easy girl, not tough. And so went right there. Actually, we know that everything diffuses better mesially. So I chose to go between the 2nd molar and the 3rd molar and took care of that swiftly. And Abigail was out of there, I mean, under 10 minutes. Very good. So this is Gerald. He weighs 135 pounds. We're doing a 29 DOB. We're doing number 30 MODB. These teeth had some hypomineralization on them as well. We gave 2 injections, 1 carpule, 4% articaine. So looking at him again, looking pretty good. That trabeculation, it goes pretty much to the top of the crest. So sure enough, popped in so easy on him, nothing to it. Class 2 composites on permanent teeth take a little bit longer. So there we go. Now this is Rhea, 73 pounds, and these look like such easy teeth, but I am going to tell you, they both had that palatal root that wrapped around that premolar crown, and they were actually tricky. But my recommendation to you, use a 39R and a 39L, and you won't snap those palatal roots off, and it'll do great things. But anyway, 2 injections, very easy. Again, her bone, very, very easy, very straightforward. This is a child with sick teeth. So sick teeth have a lot of mottled bone around them. which makes it easier to get into the bone, but you don't want to inject into a space that has a radiolucency. So we did multiple injections here. And I want to point this out because it's really important. I wasn't really happy with the amount of infection back here and obviously the bone. So when I injected here, I aimed a little bit further down the ridge. And we know, particularly in the mandible, when we're up on the crest, the bone's easier to get in. The more you descend down the mandible, the more organized and highly corticated that bone is. But I was actually able to inject down here. So I gave that injection, that one. Did the same thing on the other side. I actually aimed a little bit lower for her and everything went well. All right, Bryson, 35 pounds, ENF extraction, just one injection, half a carpule, just right there. Everything was great. All right, I want to point out, so this little friend, so this friend's pretty little, but I want to point out a couple tricky little places because I really want to get your attention. It took me a while to be like, what the heck is going on? Or like, why was that so easy? And this is suddenly hard. So for example, hyperfocus on the bone between tooth 19 and tooth K. I want everyone to appreciate on the crest of the bone how opaque that is right there. That is going to be a more challenging place to inject into versus look at it on this side. For whatever reason, it's less organized, it's less opaque. This bone is going to be much, much easier to inject into. And in fact, when I look at the bone, for example, between S and T, I'm like, yeah, that could be a little tricky there. I like the way, again, between T and 30, it's a little less organized. A little less organized. Look at how dense it is, for example, between J and 14. Start looking at these things. You really don't want to stick your needle where the periosteum is highly organized, corticated, and opaque. That's where you're asking for trouble. So also, by the way, we put a TP sep right here to get tooth 3 to jump. And I always do a little dot. So for example, I just basically do the blanching mucosal step right there to get the TP separator in there to institute the jump, bring them back in 3 weeks, take that out, put an elastomeric in there, and then deal with it from there. But in this situation, I went for it. I went between the spots because I needed to anesthetize. I had to get number 19. It needed an OB. If I were, for example, treating tooth K, I would have probably avoided that area, but it went in. It took me a second, but I got in there. All right, let's look at Nadia, 49 pounds. We're doing DOs on BNS. And again, looking pretty good. And ironically, we always think of the mandible like that's the easy one. We start there. So if we dull our needle or if we have a hard time with it, whatever the situation is going to be. In this situation, I can 100% tell you going into this, I knew the mandible was going to be easier. And I knew the maxilla was going to be more challenging based on the opacity of the crest. So you see how, especially right here, this is glorious. This is not very well organized. You're going to drop in there and it's going to be great. Little denser up here, but we still got in and we did very well. This is an old pan, so it's not a great example, but this is just showing the process of day, taking out a couple teeth. Same thing here, not as much to learn from it. Here's a fresh one. So this is Brooklyn, 39 pounds. We're doing bioflex. She also has oral findings consistent with GERD or a highly acidic diet, a lot of wear, actually a little bit of sensitivity. It's kind of a highly sensitive child. But what we did was one injection. We did 3/4 of carpule, and we did bioflex on K and L. Why we know that the drift is better mesial, we know that, but she was a little bit of a fussy one. And I felt much better about being very predictable, dropping in right there. And I think actually what I did, because I really wanted the raincoat on this tooth so I could keep everything tidied up really nice, I dropped in right there. Things went pretty well. And then I dropped in distal of it, and it was a little bit of a struggle bus, but I got in enough where I could put the raincoat on that partially erupted tooth 19, just not even enough erupted to seal, but enough where I could complete those restorations and clean them up and everything with the raincoat on. All right, this is really a sad situation. Super, super, super sad. This is a friend that came to us, and Heidi was still there. And this child, I don't know how many places she had been, but her mom reported that for 2 months she had gone to multiple offices, and every week she would just get a new antibiotic because she had so much pain from tooth 19. It was just really such a sweet, sweet girl. And I was actually in the OR the next morning and offered to see her there because she had just not slept, not ate, not did anything. And this child was like, no, take care of my tooth. Let's take this thing out. So what we were able to do is 2 injections. We did 1 full carpule. And this little girl went from being everywhere on the planet, taking all these antibiotics, and 2 injections later, and that took a couple 3 minutes, and the tooth was out of there, and the whole procedure was less than 5 minutes. It's one of those sick infected teeth that just basically jumped up into the forceps, and she was taken care of. All right, and then Heidi gave me a little present for spending the day with me, so that was pretty sweet. So we have a few more things to talk about, but I really want to sculpt this to what you guys need tonight. So not only tonight, what you want to focus on, this is free response. You can write anything you want here, but what would help you in future webinars? Do you like seeing the videos? Do you like seeing the x-rays? We have so much of everything. I have more to show you, but I'm going to focus on what the feedback is. So you can take your phone, you can chime in, and we will get to the questions at the end, but just really, what is helping you learn? Are you starting to understand how the bone works? More videos. Well, we have some more videos for you. Don't worry about that. Seeing how the angle of insertion, we'll put more videos, more cases, radiograph, videos, diagrams, videos of placement, videos of, yes, cases that didn't go well. Well, I have some bent needle cases I could show you. Videos of cases with abscess and where to get in. How do you handle replacing a needle? What do you say? Oh, I'm just going to switch this out to get one for this next spot. You can come up with some very, very key things. So, all right. All right, this is good. All right, let's go on. So you want to talk about videos? Let's do videos. This is a really anxious little friend. This is the blanching step. You see the blue. You see my favorite dental high-tech device. This is popping through for her. And I know I try to look away with my loop light so that it doesn't bother people. You see me holding it with my left hand right now. I hold it with my left hand because I feel very secure about what's going on, and I'm looking for blanching. Especially if you have a friend, and you can see her eyes, she doesn't care. She came in fussy and everything's good, but I'm looking for that blanching to show my diffusion. Get her a little sip of water, she's doing great. We're gonna put that raincoat on and pick up the handpiece and get to work. And we're just going to start prepping, getting things along. Yes, I don't always, but oftentimes cut dry most of the time. Keep the tooth cool, burr cool, mirror clean. Dental assistants are trained. We're doing everything. She's doing really well. Slow speed, doing the caries removal. And I bring all these things up because I'm going for it here. And why am I going for it? Because I saw that blanching contralateral, and I know there's no way in the universe this child couldn't have complete and profound anesthesia unless there was appropriate diffusion of that anesthetic. And I think I'm doing I don't even remember now, but I think I'm doing BioFlex here. Those caries were deep you could see how deep they were without sign of pulpal exposure. I test fit those BioFlex on, and we call it Bon Jovi in it. I live on a prayer. I do my distal smooth up and a little bit more prep around the distal. I know some programs train not to prep the distal of the E when the 6 is interrupted. Well, first of all, you'll never make that work with zirconia or BioFlex, but I strongly recommend that you carefully do that even with stainless steel crowns and get everything done. And this is us cementing these BioFlex. And then this is a 10-minute procedure, start to finish with this little friend for 2 BioFlex crowns. I'm here to tell you, you shouldn't be using the pusher on BioFlex. I will tell you from having 4 recare cycles of BioFlex, what's more important is having a fully seated BioFlex versus how you're pushing it down or what you're choosing to do. And that was that case. And you guys can put questions in if you want, and it went really well. So one singular injection for her. All right, let's see. I think this friend, I've shown this case before, but people frequently ask me, can you show me taking out permanent teeth? I really want to see what that looks like. So this friend made the option. This is a private pay family. We kept referring to ortho due to this impacted canine, and finally they're like, we just can't do this. What else can you do for us? And I want to unpack the way this looks on this child. When we talk about hypercortication and this ridge, you see that nice, dense crustal bone. So I know I'm going to need to breathe and open this door with kindness for her. She too is very anxious, and here we go. So we're doing our blanching step, and we do have equal numbers, Soan and SleeperOnes. I'm showing you videos of only SleeperOnes right now. They all work the same way, but there's our blanching step. And what I'm going to do, over blanch, as we all do, and then we're going to come out and we're going to come in and pop through that cortical plate, and shoop, it goes right in, and I'm leaving 1 to 2 millimeters out. Now you'll see me look with the mirror in just a minute. And if I'm not satisfied with seeing that blanching on the palatal, I don't even remember. If I am, I'm only going to give 1 injection. If I'm not, I'm going to go to another place and take a look here in just a minute. But one thing to point out, and this is just regular time, so we're taking our time going through this. You can see the plunger going. When everyone gets their devices, they try to watch the plunger instead of the light flashing to know that it's actually going. You can make your eyes go cross-eyed watching that. And remember, when you're doing the drop by drop step, you're not going to see that plunger move. So don't even give it up. Don't even look at the plunger. The drop by drop step on the middle pedal, do your blanching, and watch the light blink. That's all you need to do. And then I'm coming out. I just decided I was going to go for it. I think she was highly anxious. I feel like I over anesthetize for those children. You saw me do the spin to pop through it a little bit more. One thing I've learned is that now I'm looking and I'm like, okay, am I seeing that blanching? I hope everyone can appreciate in the mirror the blanching on the palatal side. That tells me that diffusion is glorious. One thing I'll let you know, it's a tricky little thing. The canine prominence is a highly corticated place because we know form follows function. The canines are the pillars, the cornerstones of our mouth. They are our interference teeth, how we guide things, and the bone responds in strength. So don't let canines fool you, even little primary canines. They can be very, very tricky and sometimes very tricky to pop through. I want everyone to see as I finished in this carpule, what's actually left in this carpule. It's going to retract in just a minute, and it's retracting now or I wouldn't have come out. So that's about a little less than 1/8 of a carpule. So I saw the blanching. I don't test anything. I pick up, I'm taking out that primary canine and that premolar, and I go immediately to the soft tissue release. Don't think twice about it. Usually don't use elevators on permanent teeth or primary teeth unless they're ankylosed, but I do on permanent teeth, especially 2-rooted maxillary premolars. Those little guys can be tricky little devils sometimes to make sure everything's good. Holding, of course, the cortical or the alveolus to make sure my expansion isn't overdoing it. I can feel the plate release as I am helping this canine or this premolar on its way. And there we go. We're going to just curette that out, take care of things, and call it good. And that's a permanent tooth. I get a lot of requests to show videos of removal of permanent teeth. Everyone needs to appreciate I gave no palatal injection. Never a palatal injection. Not going to do it again. All right. Let's go to the next video. People ask questions to me frequently about seeing blood in their carpule when they're done. You absolutely don't need to aspirate, but if you push your syringe all the way until it retracts itself, it's pressurized and then it retracts, it is aspirating as it retracts. So that's just a little bit of bone marrow, a little bit of blood from the trabeculated blood. Don't worry about it though, it's all good. Nothing to write home about. People say, I see children with Medicaid. Is this just too much money to be able to do that? No, I don't know how you see children with Medicaid. without having this device. It saves so much time, and you can take care of so many more children. Our practice, for those that know us, we're dichotomous. I feel like we're bougie. I came from Virginia to do a full mouth zirconia with you, and then it's really sick children that automatically qualify for Medicaid, but we use this all day. And for those with special needs to not have peripheral numbness, it's profound. Hypomineralization, again, if you look at the research, it's really sad. Local infiltration renders less than 30% of profound anesthesia, where this article talks about nearly 90% for intraosseous, and this article talks about pushing 95% for intraosseous. So it's a really great thing, and it's changed the world of hypomineralization. And I even say it changes my approach. So many people, their first go-to with hypomineralized molars will be glass ionomer. And why? Because they're looking for that chemical bond instead of that composite bond, because oftentimes they're not able to always remove all the affected tissue because they feel like they're hurting children. And they are. Sometimes everybody's doing the best they can, and it still hurts the children. So that's our go-to. When you use intraosseous and you have profound anesthesia, you can completely 100% remove that affected tissue. You can restore with composite, which we know oftentimes, unfortunately, these teeth involve the ridges in load-bearing areas, and it really provides a stronger, more durable, more polishable, more aesthetic restoration for these kids. So it's a game changer. And this is just a sad situation. This was clearly a combination of molar. I saw this child on emergency for our county. Clearly a combination of likely molar hypomineralization and probably pre-eruptive caries, if I had to guess. And in this situation, if you were to approach this, you would definitely want to go anterior and posterior to this tooth to make sure you have adequate anesthesia. And again, angles. I'm going to talk about Clark's fingers again. So this is the first step, the blanching step. This is a pretty traditional angle for what we're going for with intraosseous anesthesia. But if you're having trouble getting through, just come out, steepen your angle just a little bit, because as we know, the bone gets a little bit less dense as we get up on top of the crest. Now, be cognizant to not make your angle so steep that you pass through and you pass right out and you end up doing an infiltration. And I have done that before, so keep an eye on it. We talked about blanching as a confidence marker, and you don't need it every time. If you're doing a composite or straight crown or something like that, you don't have to see that. You can do a single injection, you pop into the bone, you're good to go. But if you're pulpally involved or you're removing a tooth, I would strongly look for blanching on the contralateral side. If not, given another injection, in front of the tooth or behind the tooth, depending on where you are. And if you see blanching in the vestibule, that's bad. That means you've passed through, you've come out, now you're back in the soft tissue again, which is not the end of the world. Now you're doing an infiltration. So you want to come out, re-angle, get back in that bone where you belong. This is a little feller. You're going to see this. I like this little case because it's just one of those. You pick it up, you see it, you see the caries on that tooth K. You come in, you do your blanching, you come out and then pop through. And I will let you know, the further you get back, the angle gets trickier, especially if you're working on a second permanent molar, especially when you use nitrous, because that nitrous nose gets in your way just a little bit. So be cognizant of your angle. Make sure that you're paying attention, that you're not getting into the PDL space. Because if you're in the PDL space, and for example, if I were in this situation and I were doing tooth L as well, it wouldn't be anesthetized. Obviously, just doing that one tooth and it works just fine. But everyone needs to know there's no delay. Do not get up and go check recares. Stay put, take care of that kid. Again, crossing the mucogingival junction, you can use intraosseous all day long for complex surgical procedures, but if you are flapping, which normally passes or puts enough pressure on the mucogingival junction, you need to infiltrate around that to ensure adequate anesthesia. This is not me, this is one of our colleagues in France, and she's doing the intraseptal clearly on a grown-up type person. You'll see her blanching step, or him, I'm not sure. Sorry, Dr. Gale, whatever you are, boy or girl. I'm not sure if Clotilde, maybe sounds like a girl, like Matilda to me, but I don't know. But this is the blanching step, and you're gonna see we get it really, really well. And this is clearly someone older with facial hair and all this stuff and a wisdom tooth back there, and this is popping through that intraseptal. The reason why I love showing this, because this is that probably I don't have any videos of people with wisdom teeth in their mouth, but I love showing this because I am certain our colleague here is not expecting to get 1 tooth distal and 2 to 3 forward, because that is a 9mm needle on a full grown man. They're expecting to get intraseptal anesthesia, which means what they're getting in this situation is 230 and 231. And if they were doing something in front of that, they would come forward and do another. All right, we talked about 2 injections, can't reiterate it enough. The biggest thing I've learned is when the kids get bigger. So for example, in PALS, we consider a 9-year-old a grown-up. That's, PALS is up to 8, I believe. I would consider your intraosseous injections the exact same way. If you have a 9-year-old or above, and you're using a 9mm needle, I would say in my mind, I am doing intraseptal, and I am expecting to get 1 tooth in front and 1 tooth behind for wildly profound anesthesia. So the other thing to keep in mind, and sometimes this happens, I mean, stuff happens, things are harder. How many times have we gotten to a situation, class 2 composite, where that darn band didn't want to fit down because the contact was tight or something, and you fiddled around, it took you longer than you thought, and then you're trying to do something forward. If it's taking longer than you think, and people say, well, how long does it last? Well, that depends on how much you give. That depends on if you're doing 1 to 100,000 or 1 to 200,000 epi. In my hands, I only use 1 to 200,000 epi now, 4% articaine. I like to tell myself I have 30 minutes of profound anesthesia, but my goal is to have that quadrant done in 20 minutes. And if I'm not done in 20 minutes and I'm not just, restoring, or if I'm continuing to prep or do something, which would be not normal unless it was zirconia crowns with pulps and things, I would probably add a little bit, assuming that we have enough local anesthetic per the weight of the child to handle this. All right, people say, oh my goodness, I can't believe you're sticking the needle in the bone. Why would you do that? Everyone relates it to our PALS training again about doing IO emergency medicine, but very different. That is a 16 to 18 gauge needle in their leg and their tibia. So this is very different. We're using a 30 gauge. And the impact of your workflow. So I did a calculation in our office. If you take every doctor and their operative dental assistant, when we used to do ops, we would anesthetize and walk away. So that happened to be 8 gloves for every single friend that we saw in our practice. So now that we're only doing four gloves per friend in our office, the calculation for us came to each doctor saving $5,000 a year. So in our practice, that's $35,000. It's huge, not to mention the environmental impact and then the efficiency of it all. We're seeing way, way more lucky day friends, which are exams or recares, that we're able to do treatment the same day. Everybody's happier. The children, the operative children, are in the chair half the time they used to be, and they're just so much happier. Even if you have fancy dental chairs, it just doesn't feel good laying in a dental chair for a long time. Even if you have a movie, Elsa can only entertain you so very long. So everyone's happier. So again, what have I learned? Prepare the parents that you're going to be there a while. When they think of injection, they think of being at the pediatrician. Oh, today my child is getting their chickenpox vaccine, and they pop them in the leg, they squeeze it out, and they're on their way. And here we are hanging out 2 to 3 minutes. They don't like that. It seems scary. It seems torturous. So you need to tell them, I just want to give you a heads up. We have the state-of-the-art way of delivering local anesthesia here. But it does take longer because it's a digital delivery, which makes it virtually painless. And we're going to sit, and we're going to talk, and we're going to hang out. I tell kids I'm taking their temperature. Oftentimes they can see the blinking light, especially on the SleeperOne 5. And I'm like, when it's done blinking, that'll tell me it's got your temperature. And we just hang out and we watch that, and we watch Lego movie or whatever we're doing. We talk and we hang out, but you do need to prepare parents. You want to make sure you retract your plunger before you switch the carpules. And especially, probably one of the downsides to the SleeperOne, on the Soan, you can retract the plunger on the foot pedal and you can retract it on the handpiece. But on the SleeperOne, you only can retract it on the foot pedal. So if you have the foot pedal on your side of the chair and you're moving on to another quadrant and you hand the device over to the dental assistant, and I want you to switch this out, they're going to get frustrated with you. They're like, push the pedal, because they have to wait for it to come back. And so they're going to get impatient and try to unscrew it. So as soon as you're done, you're done with the cartridge, teach yourself just to touch that, retract that pedal, so they're not tempted to be impatient and potentially put pressure on your plunger, which is very bad. And it's probably the most sensitive part of the device, if I had to guess. And the other thing to know, you can pop a cartridge out of anesthetic and switch it out real quick on a conventional syringe with the needle on. You have to remove the needle to release the carpule, generally speaking, with these devices. A great rule of thumb, Jordan and I have been interacting with one of our colleagues about why her device, she's going, then all of a sudden it's like, no, I'm game over, I'm retracting. Chances are she has a lumen plug. So when you get the better and better and better you get at using these things, the more dense bone you pass through on the older kids. But that also means you're passing through bone and you're capturing this little piece of bone, this little lumen plug. And sometimes, the device can't tell you why it's having a hard time pressing. It's just like, this isn't working. And I'll be like, no, you're going to hurt somebody here, and it'll retract the plunger. Now, if you're on your game, you'll see the pressure indicators when they get to 3, or in the SleeperOne, it starts rapidly. You're like, something's not right here. Take your foot off, try again, reposition the needle a little bit. And if all else fails, take it out, switch the needle, and go back. Most of the time, you'll drop right back into the spot you were in, and all is well. And the last thing I want to talk about is the value of dental high tech in the OR. And a lot of people are like, oh, I don't want to do this. They can't feel anything, and so forth, so on. Sometimes I see the emergence delirium, particularly in those with special healthcare needs. And even though it's not my job to recover them, I can hear them. And I feel so sorry for them and their parents and our team who recovers them in PACU. And sometimes I think, maybe we should be using these in the OR. And some people do. I know Sarah Werb does. She's in the OR. It's great. And I have done it a couple days. And the funny thing is, normally when we deliver local anesthetic, and in our surgery center, we only have lidocaine, 1 to 100,000. You can hear the heart rate pick up when we deliver lidocaine. You don't hear it when you do intraosseous. So there's that. The other thing is not having this peripheral numbness. So they're already, from the narcotics, they want to touch their nose and do weird things. And then their lip, they want to chew their lip, and they're not happy about that. So it's something to think about, just something to think about. It doesn't mean it has to be used for conventional care. So we're back to where we started again. I want to give a little bit more time. We're open to all comments. I don't know if you enjoyed the Mentimeter. There's some games we could play. We could do quizzes and ask questions. We could do cases and give examples of ways that you could approach it. The sky's the limit, but you have my contact, so jump out there and ask. And you have these guys, and they talk to me on the routine. So I'm gonna turn them back over to them. I'm gonna drink some water, and I'm here for you. We've got 15. Oh, we're almost out. Goodness, time flies when you're having fun. I'll be here till you don't need me anymore.
All right. Thank you. We'll actually use this time real quick. I want to introduce Erin as well. She doesn't have a picture on here yet, but we have a new team member here at New Smile that's helping with onboardings and demos and trainings and answering questions. So Erin, you're on the call if you want to introduce yourself.
Hi, I'm Erin. I am, like Chris said, I'm new to the team. I'm excited to be here, and I've just started onboardings myself and demos. So I'm sure I'll be talking to a lot of you guys soon.
Awesome. And we'll include her contact info in the chat as well, so you guys have that. So you have 3 options. But let's dive into the questions. We got a bunch. First one, you ready, Dr. Johnson?
I'm ready. Let's do it.
All right. Where would you anesthetize if doing a pulp SSC on K?
On K. So I will let you know if it were mixed dentition, I would do distal to K. If it were primary dentition, I would do mesial to K. And the reason why is I would want to be careful not to be near the follicle of the unerupted 6-year molar. Sometimes it snuggles up against that distal side. But sometimes, let's say it's a gnarly infection, I would look carefully at that radiograph. And if I felt like it was an infected tooth, I would do mesial and distal from the buccal. And depending on the weight of our friend, and depending on if I was doing L2 or whatever, but generally if it's just K, I'd probably do a half a carpule, unless it was infected. And then I might do 3/4.
All right, thank you. Next question is, can you elaborate on the lip/chin paresthesia?
Yes. So when you think about the mandible, so let's say, for example, you were doing an occlusal on tooth 28, and you're dropping in intraosseous distal to tooth 28. And most of us overblanch, and depending on the innervation and the morphology of the innervation, sometimes we'll capture a little bit of that mental nerve with our blanch, and sometimes with the diffusion of our intraosseous, we'll capture a little bit of that nerve as it's exiting the mental foramen. But it's not like we did a block or a long buccal. It's very, very different. So the lip might feel like, oh, my lip is, they might even say it's numb, but it's not, I'm going to chew a hole in it numb. It's just paresthesia. It's just a little bit of numbness.
Awesome. We had a comment, I guess it was a late response to one of the polls that you had up there, but a request for more permanent tooth cases.
All right, you got it.
Next question is, can you talk about the differences again between cruise and drive mode?
Yes. Okay. So drive is like you drive your car. You step on the pedal and it goes. And oh, by the way, this is only with the Soan. The SleeperOne 5 does not have these options. The cruise mode with the Soan means you tap it once and it's just going to go. And it's going to go to one or two things happen. Either you tap it again, or you finish the carpule, it pressurizes itself and self retracts. The very, very important thing to know about this, especially if you're new to the device and with the permanent dentition, you're still delivering inferior alveolar nerve blocks with your device, it's very important that you realize if you are in the cruise control mode, you can't go to the aspiration and aspirate and ensure you're not in vasculature until you stop your cruise. It stops, and then you go up and you press on that upper left side of the pedal and you aspirate there. Very important. And some people really love it. We have one doctor in our office, Clark made the decision. He's like, okay, everybody, quit putting it in cruise control because we're all expecting it to be in drive. We're just going to all do the same thing because it gets kind of frustrating. And one of the dogs was like, oh man, I like that because I like kick back, cross my legs, put my hands up for a while, stretch it out, and just, don't have to be very focused on it. So it's all personal preference.
Great, thanks. Next question is, do you ever give less than half a carp, like for just a BDO? And if you're doing an AMO/BDO, how much do you use and where do you anesthetize?
Oh, that's a good question. So less than a half a carp would only be, one of those scraggly hanging by two fibroblast over retained teeth, something that's really not involved at all, or I'm anesthetizing in place of TP sep or something like that. So I would say if we're talking about dentistry, no. As far as the MODO, primary dentition, if it's a little tiny boop boop, a 20-pounder, and sometimes these kids are so petite, for A and B on a little tiny kid with a little alveolus, I would probably do half a carp. some of our little friends got a little bit more bonkety bonk and stuff going on, a little thicker alveolus and things happening. And, sometimes on that 5-year-old, they weigh 60 pounds and their mandible is a real deal if you're working on it, or maybe their alveolus, a big broad arch, it's gonna take up a lot of volume of solution. I might do 3/4, maybe. That would be kind of if I pulpally involved or something like that for 2 primary teeth. But MODO, generally, it's a half a cart for the little dinky guys.
Great. Next question is, when you do the second injection to mesial of the tooth, do you do the initial blanching step again, or can you go straight into IO? Assuming
No,
that the tissue
go
is
straight
somewhat.
to IO. Yeah,
Yeah.
go straight. The only time you need to reblanch is, let's say you're giving an injection on me and you anesthetize, mesial to 31, but then you're also going to prep my tooth 28. Well, if you used a short needle, you just did an intraseptal, so I don't have that blanching probably right there. I would do it again. But for children, once you blanch a quadrant and give 1 IO, they have enough anesthesia where you can just pop into the bone someplace else.
All right.
Primary dentition.
Next one. Next one is, how do you balance the recare recall exams with restorative visits?
That is such a good question. And I will tell you, there's a learning curve to this because we're so programmed to anesthetize and go see exam friends and then come back and do the thing. So now, basically, you must, in my opinion, depending on what your goal is, if you want a highly productive, busy practice, which you may or may not want, if you want that and you want to move efficiently and keep things going, you must have interrupted recares. So generally speaking, when we're transitioning operative patients, and we normally see 2 operative friends an hour, I will go out into the open bay. I'll see every exam, new patient, recare, infant, appliance, emergency, whatever is going down. And then I retreat to the operative spaces. And normally I have 2 friends sitting there and I sit down, whichever one's the fastest. I sit down and anesthetize start to finish. And then I do the other one, sit down and anesthetize start to finish. Sometimes they're staggered, sometimes they're not, sometimes they're siblings, parents want them at the same time, whatever the situation is. But I sit down, start to finish, and don't get out of the chair. Once I finish those ops, I go back out, and I check all the recares, exams, and do the whole thing again. And it runs really smooth because you're not spending as much time on ops anymore. Not at all. And a lot of people ask me, like, well, I don't put the raincoat on, I don't do any of that anymore, the dental assistant. Well, if you're a raincoat person, which I'm both, I use isolate for sealants, I use a raincoat for restorative. If you are a raincoat person, you just quickly put it on yourself, which takes about 2 seconds. You guys saw me do it in all those videos. I just pick it up, put it on, get on with it. So yes, you lose the luxury of someone else isolating for you in this situation, but you save time by a landslide and you move rather swiftly.
Thanks. Next question is, do you recommend we update our consent forms with the product name, the fact that we are doing IO anesthesia, ?
Wow, that's a good question.
Mm-hmm.
I will tell you one thing we do is we do write it in our clinical notes, what the delivery is. We absolutely do, the local anesthetic we use, the method of delivery, what went down. But I don't feel the need to do the consent forms because when parents give me consent, I don't get consent for an infiltration or a PDL or an inferior alveolar. So I don't, it just, they render consent for local anesthesia. But that's a great question.
Yep. What is the aftercare pain compared to infiltration? You have a tiny hole in the bone now? ? Thanks.
No, I mean, that's just nothing. I would say that little tiny hole in the bone is nothing compared to peeling the soft tissue of the palate off the alveolus. I think that is, or depositing a large bolus of solution in the vestibule that also displaces the soft tissue. We just don't see anything. Now we do, as a rule of thumb, unless there's contraindication medically, or the parent just doesn't want it, or in situations where we have so many special friends on a ketogenic diet. But if all the planets are in line as they usually are, we ask the parents to give ibuprofen 30 minutes before every operative appointment. And if they forget, we give it to them with parent consent upon arrival. And I find it just works gloriously. Back a long time ago, I've been doing this for 15 years. One of my friends who's a pharmacist said, everybody should do this. And before that, it didn't happen all the time, but sometimes kids would leave so happy. And then when the anesthesia was wearing off, that pins and needles feeling like your foot is waking up, the parents would call back that they were crying and said it hurt. And if you do a little bit of ibuprofen 30 minutes before the appointment, you just will never have that phenomenon happen again. And we haven't.
Okay, so along those lines, we had another question. I've had a couple of cases where I completed pulps and crowns and extractions with no problem using the Soan, and then the patient is complaining of significant pain when getting ready to leave the office. Does the anesthesia wear off that quickly? Do you give Motrin pre-op?
That's really interesting. And, I think there's a chance of that. If you are doing a quadrant or half mouth, and let's say you're doing pulps and zirconia, they're going to be there for a hot minute and delivering conventionally. So perhaps it is wearing off. But yes, going back to, I'm sure you wrote that question before I said that, everybody gets Motrin before they sit down. Everybody. And if it's a toothache friend and their parent gave them Motrin because they had a toothache when they came, we give them Tylenol. We double up. We want everyone to have a very happy departure and no callbacks.
Great. Next one is, my Soan tends to drip anesthetic drop by drop when I turn on the device, but the pedal was not pressed yet. What am I doing wrong?
When you turn it, like when you just turn on the handpiece, like turn it on, it starts dripping.
What it sounds like, yeah.
I haven't had that happen. I know a lot of people, so there's a few scenarios and people videotaped and sent to me some different things. But most people were having that happen when they came out and they were accidentally in cruise control. And then some people didn't realize that they stepped on the pedal, like reaching for the rheostat pedal, stepped on the wrong pedal and got it dripping or did something again. And then some people, for example, the blanching step, they took the pedal off and simultaneously came out with it and it drips. So whether I'm intraosseous or mucosal, I take my foot off the pedal, I say 1 Mississippi, 2 Mississippi, 3 Mississippi. I come out, I immediately wipe the tissue because sometimes like a little bit, like a drop will squish out the hole. But I haven't had that happen. Have you guys heard that, Jordan, Chris? Any?
Yeah, I would add, there's a natural, pressure effect that happens when you first set up your device. So that plunger, even though it hasn't been pushed in using the pedal, once you slap everything on and everything gets set up, there could be a little bit of a drip that comes out. If it's really extensive, as if you were to have your foot on the pedal and actually using the device, let us know. Reach out to either myself or Jordan or Aaron, and we can walk you through some troubleshooting. It very well could be just a setting change or something like that.
I do have a suggestion there.
Yeah.
I would recommend, if possible, because when you turn your device on, you feel like a little whirring, you hear something. It could be like kind of in its home base readjusting itself. So I'd recommend just turning your handpiece on and then loading and setting up your device, because I feel like that might be what I'm thinking of here.
Yep, good tip as well. Last comment, when I try and buy the device, it says it is unavailable. When will it be available to purchase? We are fully in stock. I'm not sure what issues you're having, Doc, but we can reach out to you tomorrow and follow up with you and get you squared away. But we have plenty of inventory in stock and ready to go. So we'll follow up with you and see if we can help you out.
Yeah, and also feel free, since you have our contact information up there right now, just shoot over an email. We can get in touch with you first thing in the morning.
Yep.
There's one more, Chris. Aaron mentioned it earlier.
Okay.
LaRee, have you seen this? So we had a doctor asking about if they're less bleeding when using intraosseous injections with 1 to 200 as opposed to 1 to 100 as compared to infiltration or block.
Well, two things. I am so glad you brought this up because one of the beautiful things, and I'll get to that question, one of the beautiful things about using intraosseous anesthesia is you have so much better hemostasis from your sockets because you're bathing those sockets in epinephrine, regardless of the concentration. It's so much closer than when you're blocking or infiltrate. It's just, it's a beautiful thing. And I find I use so much less gel foam. So I'll just say that. I wish I would have said that earlier. So thanks for triggering that for me. So the question, I think what they're getting at, when you use 1 to 200,000, it's less epinephrine, and epinephrine also provides us hemostasis. And so one would think like, oh, are you seeing more bleeding then? Absolutely not. I can't tell a difference from that aspect. Not at all. But that's a great question. I need to start talking about that. Thank you.
One more question came up. Any tricks for patients that have a thicker cortical bone? I feel like I'm not getting good penetration of the needle.
So the first thing is, if you're trying to do that 16, surrender. I was getting very frustrated with late mixed and adult dentitions trying to get a 16 through. I had a lot of bends. So that's my first bit of advice. The other bit of advice is start looking at those radiographs very specifically. Bite wings are a little bit better judge of the density of that ridge. And sometimes, even though you might want to be mesial, it might be less dense distal, and you might pop in there and have super great success and deliver a lot of an anesthetic, and then save a little bit and give it a shot in the harder spot. So the best advice I have, and it took me a long time, first of all, you got to train yourself to look for bone, where to stick this needle in where there's bone to deliver this so it can get to the Haversian and Volkmann canals. But then it was like this epiphany, like, I'm not just looking for bone, I'm looking for less organized periosteal bone places. And once you start seeing the light of like, that's what's going on, your life just gets profoundly easier. And I want to very cautiously tell everyone this, because we would never inject in the furcation of a primary tooth ever. However, on a permanent molar, particularly a lower permanent molar, sometimes because of crowding, it's hard to get, and that sometimes is a barrier, but you can inject into the furcation of a permanent lower molar really nice. So keep that in your pocket. And sometimes that bone is not as dense, especially if it's an infected tooth or something. So be creative in your approach. And generally, we don't want to go from the palatal and we don't want to go from the lingual. But if there's a big infection, we also don't want to pass the needle through an infection. So think out of the box about what you're doing. And if you do go particularly palatal, we don't want to give palatal injections, they hurt. But if you blanch from the facial to the palatal, you can sneak through there very painlessly.
All right.